Welcome back to the Deep Dive, where we take the densest foundations of medical knowledge, crack them open, and really give you the essential architecture you need to build that clinical understanding.
Absolutely.
And if you're a learner, tackling the fundamentals, especially the vast, truly vast and vital world of hematology and transfusion medicine, you know that the sheer volume of details can feel, well, pretty overwhelming.
It truly can. And today we're deep diving into the concepts laid out in foundational texts like Davidson's medicine. You know, what makes hematology so challenging is its incredible scope.
Right.
We're talking about disorders that span from the incredibly common thing, iron deficiency anemia, which affects, hundreds of millions globally,
Wow.
to these highly specialized, rare molecular conditions, like acute leukemias and congenital coagulation disorders.
So our mission today isn't just to sort of define these concepts, but to give you the cognitive anchors, the metaphors, the high-yield nuggets that make sure these complex ideas actually stick under pressure.
We're trying to provide a mental shortcut to mastery.
Exactly. We'll be talking about the iron gatekeeper, visualizing the domino effect of clotting, and using the mean cell volume as the blueprint check.
And we've woven in key clinical context and integrated some check-in questions along the way. If you can answer them, you know you've absorbed the core concept and you're ready for the next level. If you can't, it's a clear signal to just, pause and reinforce that knowledge immediately.
Okay, let's start with the basics then. Let's move from the finished product back to the factory. First, what are the four primary constituents circulating in the bloodstream? It's not just one fluid, is it? It's a living, complex ecosystem.
That's a great way to put it. You've got the primary movers and shakers. First, the red cells, whose entire mission is oxygen transport.
The courier service.
The courier service, exactly. Second, the white cells, our dedicated defense and surveillance system against infection and foreign invaders.
Yep.
Third, the smallest components, the platelets, which are actually just cell fragments. And they're responsible for maintaining vascular integrity and initiating the clotting process.
And what holds it all together?
And finally, the plasma. That's the straw-colored fluid matrix that contains water, nutrients, antibodies, and crucially, all the soluble coagulation factors.
So we have the components. Now, how are they made? The process is called hematopoiesis, the continuous creation and maintenance of this whole cellular ecosystem. It has to be continuous, right?
Yeah.
And regulated and capable of scaling up fast.
It is the body's ultimate, constantly running manufacturing line. But where this factory operates, that changes drastically throughout life.
Okay.
Initially in the embryo, it begins in the yolk sac. Then by mid-gestation, the liver and spleen take over the bulk of production.
And then as we grow up, the bone marrow becomes the exclusive site. But not all bone marrow is active, right? If you break a bone in your arm as an adult, you don't necessarily have active blood production there.
Precisely. By early adulthood, the highly active cellular red marrow has been largely replaced by fatty, inactive yellow marrow in the long bones.
So where is the factory?
The adult factory concentrates production in the central skeleton. The vertebrae, the pelvis, sternum, and ribs.
And that's a vital detail for diagnosis, isn't it?
Yeah.
It's why we take marrow biopsies from the posterior iliac crest.
Exactly.
The key functional concept here, then, is that while the factory is sort of restricted in adulthood, it remains an expandable factory.
Absolutely. If you experience massive blood loss, or if you have a chronic infection that requires a sustained increase in white cell output, the body can actually reconvert that peripheral yellow marrow back into red marrow.
So it's firing up dormant sections of the factory floor.
That's a perfect analogy.
Now let's get to the hierarchy of creation, which starts with the most versatile raw material, the pluripotent stem cells.
These are the masters of two vital tricks. The first is self-renewal, which ensures the stem cell pool never runs out.
Right.
And the second is differentiation, which is the process of committing to a specific lineage. Once they commit, they become what we call primitive progenitor cells.
And here's a great nugget for you, the learner. We can't distinguish these primitive progenitor cells by just looking at them under a microscope. They all look pretty similar. So how do we know what they are?
We know them by their destiny, which we test in culture. We actually name them based on the cell colonies they form.
Okay, so it's about potential.
Right. This is the key insight for understanding when lineage commitment fails. You need to remember three major types. First, CFUGM, which stands for colony-forming unit granulocyte, monocyte. This branch leads to your neutrophils, eosinophils, basophils, and monocytes.
The main white cells.
The main white cells. Then you have CFUE for the erythroid lineage leading to red cells. And finally, CFU-MEG, That's from megakaryocytes, the precursors to platelets.
Understanding those names seems crucial because when a disease like acute leukemia occurs, it's usually a failure at one of these committed progenitor stages, right? It leads to this explosive growth of a single immature cell type.
Exactly.
So if the bone marrow is the factory floor and the stem cells are the raw material, we need managers to control the whole production schedule. These are the growth factors.
These factors, they're proteins produced primarily in the bone marrow stromal cells, but often in other organs. They act like hormonal instructions. They dictate cell survival, the rate of proliferation, and the final pathway of differentiation.
Let's focus on the lineage-specific factors because these are enormous clinically. The absolute king of red cell production is erythropoietin, or EPO. Tell us about its feedback loop.
EPO is fascinating because its production location gives it a direct link to the red cell's primary function, carrying oxygen.
How so?
EPO is produced mainly by renal interstitial peritubular cells in the kidney.
The kidney.
When the kidney tissue senses hypoxia-low oxygen tension, it releases EPO. EPO then travels to the bone marrow and acts immediately to ramp up red cell production.
So the kidney is directly signaling the factory that the oxygen courier service is falling short.
That is exactly what's happening.
Then we have the other vital managers.
Exactly. You've got granulocyte CSF, or GCSF, which specifically stimulates the production of neutrophils and is vital for immune defense. And then thrombopoietin, or TPO, which is produced mainly in the liver. That's the key regulator for megakaryocyte growth and, therefore, platelet output.
And here's where the science becomes life-saving medicine. Once we identify these specific protein signals, recombinant DNA technology allowed us to manufacture them synthetically.
And think about the clinical application of that. For patients with chronic kidney failure, their kidneys just stop producing enough EPO, which leads to this chronic refractory anemia.
You just give it back to them.
We simply inject recombinant EPO to correct the anemia. It completely transforms their quality of life. And similarly, after aggressive chemotherapy, patients often experience profound neutropenia, which puts them at a huge risk of fatal infection. So we inject recombinant GCSF to accelerate the recovery of their neutrophil count. We're protecting them during that crucial, vulnerable window.
We're literally injecting the precise instructions the body needs to rebuild itself faster.
We are. The knowledge of this factory sister is the cornerstone of hematology.
Moving from production to the final product, let's focus on the red cell itself. We need to appreciate its shape, because its survival depends entirely on its structure. I like the idea of the red cell membrane as the scaffolding metaphor.
It's an excellent visual. The red cell is essentially an 8-micrometer diameter biconcave disc. Its membrane isn't just a simple lipid envelope, it's a lipid bilayer anchored to a complex underlying cytoskeleton, the scaffolding.
Okay.
And this frame is built primarily from filamentous proteins like alpha and beta spectrin, and it's connected to the membrane via proteins like ankyrin and band 3.
And the reason this scaffolding needs to be so perfect comes down to physics and geography, especially in the spleen.
Precisely. To navigate the microcirculation, especially the tight slits and cords of the spleen, that 8-micrometer cell has to deform dramatically to squeeze through gaps as narrow as 2 micrometers.
The 2 micrometers? What?
It's an incredible feat of engineering. The scaffolding provides the essential elasticity and stability for the cell to undergo this extreme deformation millions of times before it reaches the end of its lifespan.
So if the scaffolding is faulty, what's the immediate clinical consequence?
The cell loses membrane integrity. Every time it squeezes through the spleen, a small piece of the membrane just gets chipped away.
Right.
And this results in the cell losing its biconcave shape and becoming spherical, a spherocyte, or elliptical, an elliptocyte.
And that's the mechanism for conditions like hereditary spherocytosis.
Exactly. It's a classic hemolytic anemia, where those less deformable spherocytes are prematurely trapped and destroyed by the spleen.
So beyond structure, the membrane also controls the internal environment, maintaining crucial osmotic homeostasis, since the mature red cell lacks a nucleus and mitochondria.
Yes, the cell relies entirely on anaerobic glycolysis for energy. So the membrane is working hard, maintaining the ion balance and volume, preventing the cell from swelling and bursting or shrinking too much.
And of course, covering this scaffolding are the surface tags that define blood compatibility.
Right, the numerous glycoproteins that form the various blood groups. We primarily focus on the ABO and rhesus systems because they're the most immunogenic, but we've cataloged over 400 different surface antigens. This surface chemistry is absolutely critical for safe transfusion.
Let's move inside to the main payload, hemoglobin. This is literally the oxygen magnet. Structurally, How is it organized to carry gas?
It's a remarkable quaternary structure. You have 4 globin chains, 2 alpha chains, and 2 non-alpha chains, all bundled together. In adults, that's typically hemoglobin A, or HbA, meaning 2 alpha and 2 beta chains.
And each chain has a central heme group with iron.
Each chain contains a central heme group, which is an iron-containing porphyrin pigment. And the reversible binding site for oxygen is that ferrous ion, the Fe2+R.
And reversible is the key word.
Crucially, it has to be reversible. It must grab oxygen efficiently in the high oxygen environment of the lungs and release it just as efficiently in the low oxygen environment of the tissues.
What allows it to do that so well?
What allows this exquisite efficiency is cooperativity. When the first oxygen molecule binds, it induces a conformational change that dramatically increases the affinity of the remaining 3 sites for oxygen.
That cooperativity, that increasing affinity, that's what gives us the unique shape of the oxygen dissociation curve. And this is our primary physiological anchor, the shy-greedy oxygen partnership.
Yes, the curve is sigmoid S-shaped, not linear, and that reflects the cooperativity. The key physical change is how the beta chains behave. When oxygen binds, the beta chains swing closer together, stabilizing the oxygenated state.
And when oxygen is released,
They swing apart, exposing a central cavity.
and what immediately jumps into that central cavity when the chains move apart?
Ah, the key allosteric regulator. Tubaglobin bisphosphoglycerate, or tuboclear BPG. It's a high-energy byproduct of red cell metabolism.
Okay.
When tuboclear BPG binds in that cavity, it stabilizes the deoxygenated state, which lowers the hemoglobin's overall affinity for oxygen.
So that lets us define the greedy partnership, the right shift. A right shift means hemoglobin releases oxygen more readily at any given PO2. When does the red cell factory prioritize release?
When the tissues are hypoxic and metabolically active, conditions that shift the curve to the right, making the hemoglobin greedy for release, are increased 2-fugyl-3 BPG, increased H+ ion, so low pH or acidosis,
Right.
increased CO2, and increased temperature. This is incredibly useful in, say, exercising muscles or in a fever.
Conversely, if the curve shifts to the left, the hemoglobin is shy. It holds onto the oxygen much more tightly, delivering less to the tissues.
This happens with fetal hemoglobin HbF, which is essential for the fetus to strip oxygen from the maternal circulation because HbF doesn't bind tubulin-3 BPG effectively.
And we also see a left shift, which is pathologically dangerous when the iron is converted from the functional ferrous state to the ferric state.
That's methemoglobin.
Methemoglobin.
Correct. Methemoglobin is incapable of carrying oxygen. But even the residual functional hemoglobin is affected. The presence of methemoglobin in that tetramer forces a left shift on the remaining binding sites.
So oxygen is carried right past the tissues without being released.
Exactly. You get functional hypoxia even if the total hemoglobin count looks adequate. It's a massive physiological consequence stemming from a tiny molecular change.
We've mastered how blood carries oxygen. Now we need to ensure that essential fluid stays in the pipes when we need it to, which brings us to the ultimate regulatory system, hemostasis. This is the definition of a balancing act.
It really is. It has 2 opposing mandates. Maintain total fluidity for transport everywhere, but when the vessel wall is breached, create an instant, localized, and robust solid plug.
It's a fine line.
It is. If the balance tips toward fluidity, we bleed, we hemorrhage. If it tips toward solidification inappropriately, we get thrombosis, clots.
And before injury, the vessel wall is far from passive. It maintains what we're calling stage 1, the peace treaty.
The vascular endothelium is the active anticoagulation surface. It continuously releases powerful factors that inhibit platelets in the cascade. These include nitric oxide, a potent vasodilator and platelet inhibitor, and prostacyclin. It also expresses surface molecules like heparins that naturally inhibit coagulation factors.
But the moment injury occurs, the peace treaty is broken, and the primary rapid response system, the platelets, is activated. Let's talk about how they're manufactured.
Platelets are unique. They aren't whole cells. They're cytoplasmic fragments derived from enormous cells in the bone marrow called megakaryocytes.
Right.
And these megakaryocyte precursors undergo what's called endomitotic reduplication, where the nucleus divides many times, sometimes up to 64 aneuploidy, without the cell itself dividing.
That creates this giant multi-lobe cell that just fragments into thousands of individual platelets.
Precisely. And this entire production process is regulated by TPO from the liver.
Okay.
Once released, they circulate for a brief 8 to 10 days. And it's important to remember that about 30% are normally sequestered or pooled in the spleen, which is why a massively enlarged spleen, splenomegaly, often results in a lower peripheral platelet count.
Thrombocytopenia.
Thrombocytopenia, correct.
When injury exposes the subendothelial matrix, platelet activation happens in 3 steps: shape change, adhesion, and aggregation.
Adhesion is the critical first step. The platelet uses its GPI receptor to bind to subendothelial von Willebrand factor, or VWF, which acts like a molecular glue.
Yeah.
It also uses GPIA to bind directly to collagen.
And adhesion holds the platelet plug in place against the high shear stress of flowing blood.
Right. And once they're adhered, they need to stick to each other.
That's aggregation.
That's aggregation. And it's mediated by the most clinically relevant platelet receptor, GPIAEA. Once activated, this complex undergoes a conformational change that allows it to bind soluble fibrinogen molecules, effectively cross-linking neighboring platelets to stabilize the primary plug.
And that receptor is the target for some potent antiplatelet drugs like abciximab.
Exactly.
The platelet plug is temporary, though. To stabilize it, we require the chemical reinforcement, the coagulation cascade. This is our domino effect metaphor.
It's a perfect metaphor. The cascade involves about a dozen soluble inactive precursor proteins called zymogens, denoted by Roman numerals. When one factor is activated, usually by proteolytic cleavage, it becomes an enzyme with an A suffix, like factor Z.
And it immediately cleaves and activates the next factor in the sequence.
Right. And the key is massive amplification at each stage.
We break the domino effect into 3 pathways for testing, but clinically the process is one integrated reaction.
We have the initiation or extrinsic pathway, which is the fastest way to start the process, triggered by the release of tissue factor from the damaged endothelium. Then there's the amplification or intrinsic pathway, which is a bit slower to start but exponentially ramps up the clot using factors like 8 and 9s.
And they both converge on the common pathway.
The final necessary sequence, the SAVA complex, often stabilized on a platelet surface, converts prothrombin, factor 2, into active thrombin, or factor 2.
And thrombin is the ultimate effector.
It is. Its primary job is to cleave soluble fibrinogen, which is factor 1, into insoluble fibrin monomers. These monomers spontaneously polymerize and are cross-linked by factor 30, forming that robust, stable fibrin mesh.
And for 4 key dominoes in this process to even be manufactured functionally, they need a crucial ingredient. This is the manufacturing requirement: vitamin K.
This is a cornerstone concept for pharmacology. Clotting factors 2, 7, INETS-X, plus the anticoagulant protein CNS all require a post-translational modification in the liver to become functional.
A carboxylation.
Specifically, gamma carboxylation. And this reaction is absolutely dependent on vitamin K.
So how does the workhorse of oral anticoagulation, warfarin, interrupt this essential manufacturing process?
Warfarin targets the recycling process. When vitamin K is used in carboxylation, it's converted into an inactive epoxide form. It needs an enzyme, vitamin K epoxide reductase, to reduce it back to its active, usable form.
And warfarin blocks that enzyme?
Warfarin irreversibly inhibits that reductase enzyme. By blocking the recycling of vitamin K, you deplete the functional supply of factors 2, 7, I, X, and X, slowing the entire cascade.
And this leads us directly to our first crucial check-in.
Okay, here's our check-in question 1, a midpoint review. If you are monitoring a patient's clotting status using the standard laboratory assays, which 2 main overlapping clotting pathways are tested by the prothrombin time, or PT, and the activated partial thromboplastin time, the APCT, and which 4 specific factors require vitamin K for their function?
Take a moment. If you can confidently state that PT tests the extrinsic and common pathways, so factors 2, V, 7, and X, and APTT tests the intrinsic and common pathways, factors 2, V, 8, 9, X, X, 11, and 12, and that the vitamin K-dependent factors are 2, 87, 9, XX, then you have a solid grasp of the foundation.
And if those Roman numerals felt abstract, just rewind and re-listen to the domino effects section now.
All right, transitioning into the investigative phase. The first tool used to triage any hematological concern is the full blood count, or FBC.
This is more than just a count. It provides essential parameters using highly automated analyzers. The total counts for all cell lines, the hematocrit, and crucial red cell indices like the mean cell volume, the MCV, and the mean cell hemoglobin MCH.
It's the essential snapshot of the entire system.
It is, but a critical note for the learner. While automation is fast, you must be aware of conditions that cause spurious results.
For
example, in severe cold agglutinin disease, antibodies cause red cells to clump together. The machine counts the clump as a single giant cell, which artificially inflates the MCV and may result in an inaccurate red cell count. You need to verify these odd results.
That brings us to the importance of the classic technique, which remains irreplaceable, the blood film examination.
This is the mandatory manual step. The machine tells you how many cells you have and how big they are on average. The blood film tells you what shape they are and what's inside them. You must look for crucial abnormalities that point to specific diagnoses.
Give us some high-yield examples of what the film reveals that the machine misses.
Okay, so we look for specific red cell shapes, poikilocytes, things like spherocytes, which confirms membrane defects or hemolysis, or target cells, seen in thalassemia or severe liver disease, or teardrop cells, a major clue for myelofibrosis.
And inclusions, too.
We also look for specific inclusions like Howell-Jolly bodies, which are residual nuclear fragments, and they indicate an absent or non-functional spleen. Most critically, we look for blast cells, immature white cell precursors, which immediately signal acute leukemia.
And of course, the blood film is the diagnostic gold standard for finding infectious agents like malaria parasites.
Absolutely.
To truly understand how the factory is operating, sometimes we need to open the window and look inside. That requires the bone marrow examination.
This procedure is typically performed at the posterior iliac crest in adults, and we use two complementary techniques to get different information.
What's the difference between the aspirate and the trephine?
The aspirate sucks out liquid marrow. This is excellent for assessing the fine morphology of the individual cells, allowing us to spot infiltration by abnormal cells like plasma cells in myeloma or leukemic blasts.
Got it. And the trephine?
The trephine biopsy removes a core of bone. This is superior for assessing the architectural components. The overall cellularity, so how busy the factory is, detecting fibrosis or scar tissue, and looking for infiltration by solid tumors or lymphoma, which the aspirate might miss.
And once we have that material, modern hematology leans heavily on advanced profiling.
Absolutely. The marrow is a treasure trove for sophisticated tests. Immunophenotyping, using flow cytometry to map surface markers, karyotyping to analyze chromosomes for structural abnormalities, and next-generation sequencing, or NGS, to pinpoint specific gene mutations.
And that increasingly dictates the choice of targeted therapy.
It does.
Now back to measuring the domino effect or coagulation screening tests. You mentioned the PT-INR and the APTT.
Correct. The prothrombin time, or PT, standardized as the INR, measures how quickly blood clots when tissue factor is activated, the extrinsic pathway.
Okay.
Since this involves factor VII and X, it's the standardized metric for monitoring the dose of warfarin therapy. We aim for a specific INR range, usually 2.0 to 3.0, depending on the indication.
And the activated partial thromboclastin time, APTT.
It measures the efficiency of the intrinsic and common pathways. Clinically, it's vital for monitoring high-dose unfractionated heparin, or UFH, therapy.
Okay.
And we typically aim for a therapeutic ratio of 1.5 to 2.5 times the control value. If either the PT or APTT is prolonged, it immediately flags a deficiency in factors or the presence of an inhibitor.
How do we figure out which one it is?
That's the beauty of the mixed test. If the patient's plasma is mixed 1-to-1 with normal plasma and the prolonged time corrects becomes normal, it means the patient was simply missing a factor, a deficiency.
Like in hemophilia A.
Exactly, factor VIII deficiency. If the time does not correct, it means the normal plasma was unable to overcome something that is blocking the factors, which points strongly toward an inhibitor or an antibody, like the lupus anticoagulant.
Finally, investigating the predisposition to clotting thrombophilia. Who gets tested and what are we looking for?
We generally limit extensive thrombophilia testing to patients with VTE who are young, under 45, have recurrent clotting, or have thrombosis in unusual sites like the hepatic or cerebral veins.
And what do you look for?
We look for hereditary deficiencies in natural anticoagulants like antithrombin, protein C, and protein S, and the two most common genetic variants, factor V Leiden and the prothrombin G2210A mutation. These tests help guide the duration and intensity of anticoagulation.
Anemia is arguably the most common hematological problem globally, and thankfully, the FBC often provides the blueprint for diagnosis. We classify anemia based on the mean cell volume, the MCV, the size of the red cell. This is our essential blueprint check metaphor.
This metaphor is perfect for the learner. The MCV tells you why the cell production process went wrong. The marrow needs to complete 2 tasks before the cell is released. Acquire enough hemoglobin and complete DNA synthesis and division.
So if the cell struggles to make hemoglobin due to lack of iron or a globin problem, it has to undergo extra cell divisions to reach the minimum HB concentration needed for release.
That results in a small cell, microcytic anemia, with a low MCV. The classic causes are iron deficiency anemia, IDA, and thalassemia. It's a defect of hemoglobinization.
Conversely, if the cell struggles to complete its DNA synthesis and nuclear maturation, the division process is arrested.
That yields a large cell, macrocytic anemia with a high MCV. This is typically due to vitamin B12 or folate deficiency because they are essential cofactors for the DNA machinery. This leads to what we call nucleocytoplasmic asynchrony.
Meaning the cytoplasm keeps growing, but the nucleus can't divide.
Exactly, creating a large, oversized cell.
Let's start with ADA. In developed nations, for men and postmenopausal women, what is the non-negotiable first step in investigation?
You have to rule out chronic blood loss, specifically from the gastrointestinal tract. This means investigating for malignancy, peptic ulceration, or continuous NSAID use.
But globally, the picture is different.
It is. Globally, chronic parasitic infection like hookworm or schistosomiasis is often the primary driver.
The mechanism of iron regulation is governed by one small protein we mentioned earlier, hepcidin. This is our iron gatekeeper.
Hepcidin, produced in the liver, is the central controller. When inflammatory signals, particularly interleukin-6, are high, hepcidin production increases. Hepcidin then binds to the iron export channel, ferroportin,
Which is found on enterocytes and macrophages.
and causes its internalization.
And what is the immediate effect of internalizing ferroportin?
Iron is locked inside the storage cells. It cannot be exported to the plasma for use by the bone marrow. This mechanism is the entire explanation for the anemia of chronic disease, or ACD. In ACD, the body often has adequate iron stores, so high ferritin in macrophages, but inflammation raises hepcidin, preventing the mobilization of that iron.
This gives us the crucial pattern of iron studies that differentiates true IDA from ACD.
In true IDEA, all iron compartments are low. Low serum iron, low ferritin, and high total iron binding capacity because the transferrin is hungry for iron. In ACD, you typically see low serum iron, but crucially high ferritin because the iron is locked in storage, and low TIBC. Understanding hepcidin makes that complex differential diagnosis make complete sense.
For treatment of IDA, the standard remains oral iron, ferrous sulfate, for 3 to 6 months to fully restock those depleted stores. But compliance is often an issue.
It is. Patients must be warned about the common GI side effects like dyspepsia and altered bowel habits. If a patient fails to respond to oral iron, the learner must check 3 things. Adherence, are they taking it? Continued loss, are they still bleeding? Or malabsorption, are they absorbing it? Maybe they have coeliac disease.
Moving to the macrocytic side, megaloblastic anemia caused by B12 or folate deficiency. The result is the DNA failure we discussed.
Right. The bone marrow becomes hypercellular but paradoxically inefficient. This is called ineffective erythropoiesis. Many cells die before they even leave the marrow.
And in the periphery.
In the periphery, the blood film findings are classic and high yield. Large, oval red cells, and critically the presence of hypersegmented neutrophils, those with 6 or more nuclear lobes. This finding is highly specific to megaloblastic anemia.
Let's detail the notoriously complex absorption process of vitamin B12. It's like a complex dating process for a vitamin.
Indeed. B12 is released from food in the stomach. First, it binds to a carrier protein called the R protein. In the duodenum, the R protein is cleaved, and B12 immediately transfers to the vital transport partner, intrinsic factor, or IF.
Produced by the gastric parietal cells.
Right. The B12-IF complex travels all the way to the terminal ileum, where specific receptors facilitate active absorption. Loss of any step parietal cells, IF, or the terminal ileum causes deficiency.
And unlike folate, the body holds massive stores of B12.
The liver stores are so robust they can last for roughly 3 years. This explains why patients who have gastric surgery might not develop anemia until years later. Folate stores, conversely, are depleted in months.
The essential neurological feature anchor we must stress for every learner is the neurological damage linked to B12 deficiency.
This is the non-negotiable differential point. B12 deficiency can lead to irreversible neurological damage, specifically subacute combined degeneration of the spinal cord.
And folate deficiency does not cause this.
It does not. The clinical implication is enormous. If you suspect B12 deficiency, you must treat it promptly with long-term intramuscular injections. Treating B12 deficiency with only folate may temporarily correct the anemia, but you're masking the underlying deficit and allowing the neurological damage to silently and irreversibly progress.
A huge clinical pearl. Okay, switching gears to hemolytic anemia, where red cell survival, normally 120 days, is significantly shortened.
When the lifespan drops, the factory shifts into overdrive. The The bone marrow can increase red cell output by 6 to 8-fold and expands its active volume, but anemia still results if destruction outpaces production.
What are the telltale hallmarks of active red cell destruction?
You see decreased hemoglobin, but increased signs of destruction and condensation. The key diagnostic signs are increased unconjugated bilirubin from Ham breakdown, increased lactate dehydrogenase, or LDH, released from least cells, and increased compensatory output seen as reticulocytosis, a high reticulocyte count.
And if the hemolysis is happening inside the blood vessels, intravascularly, what specific signs are added?
The body releases haptoglobin to mop up the free hemoglobin. If destruction is massive, haptoglobin is quickly used up, leading to a profound decrease in serum haptoglobin. We also see methylalbumin, and eventually free hemoglobin spills into the urine, causing hemoglobinuria.
Let's look at two critical inherited hemolytic disorders. First, hereditary spherocytosis, the scaffolding defect we discussed.
HS is a defect in spectrin or anchorin scaffolding, creating those non-deformable spherocytes. The spleen recognizes them as abnormal and destroys them, an extravascular hemolysis.
And management.
Management is often supportive with lifelong folate prophylaxis to sustain the hyperactive marrow. Splenectomy often becomes necessary as it improves cell survival dramatically, but it must be delayed until after age 6 due to the significant post-splenectomy risk of sepsis.
The second major inherited defect is G6PD deficiency.
G6PD is the most common human enzymopathy, prevalent in malaria endemic regions because of the protective heterozygosity. The enzyme is essential for reducing oxidative stress. Without it, the red cell is vulnerable to oxidant insults,
Which precipitates the crisis.
typically specific drugs like sulfonamides or primaquine, severe infections, or the ingestion of fava beans favism cause oxidative stress. This stress denatures the hemoglobin, causing it to clump into visible inclusions called Heinz bodies.
And the spleen tries to remove them.
The spleen attempts to remove these bodies, resulting in episodic acute hemolysis.
Finally, the most iconic genetic red cell disorder, sickle cell anemia, which we anchor as the shapeshifter.
SCD is an autosomal recessive condition where a single amino acid substitution in the beta-globin chain creates hemoglobin S, or HbS. The mechanism is simple and devastating. When HbS is deoxygenated, it polymerizes into long, rigid fibers called tactoids.
And these tactoids are what distort the cell into the characteristic sickle shape.
Yes. Sickled cells are fragile, causing hemolysis, and rigid, causing microvascular plugging. The plugging leads to the acute syndromes, or crises. The most common is the vaso-occlusive pain crisis, severe ischemic pain, typically in the bones.
And the most devastating complications.
The most devastating consequence in children is stroke. And the single most common cause of adult death in SCD is the acute chest syndrome, a form of acute lung injury.
The treatment goal is often to increase the amount of fetal hemoglobin, HbF.
Fetal hemoglobin strongly inhibits the polymerization of HbS. The drug hydroxycarbamide, or hydroxyurea, works by stimulating HbF synthesis, which significantly reduces the frequency and severity of these crises.
Now, a specific high-yield complication, the aplastic crisis.
This is a temporary, profound shutdown of the red cell factory, almost always triggered by infection with human parvovirus B19. The virus targets and kills the red cell precursors in the marrow.
Time for a second review before we transition to malignancies. This one uses the clinical anchors we just discussed.
Check-in question 2, clinical correlation. If a patient with a known chronic hemolytic state like hereditary spherocytosis or sickle cell disease presents with sudden severe anemia, a very low reticulocyte count, and a preceding viral rash with flushed cheeks, the slap cheek syndrome, what specific life-threatening complication of their underlying disease should you suspect?
The required answer is an aplastic crisis due to parvovirus B19 infection. The triad of severe anemia, a preceding viral illness, and a very low reticulocyte count indicating factory shutdown rather than increased destruction is essential for this diagnosis.
Exactly.
Right. Hematological malignancies. These represent the failure of regulation in the foundry uncontrolled clonal expansion of a single cell line. We start by dividing leukemias based on the maturity of the cells proliferating.
Acute leukemias, ALL or AML, involve the explosive proliferation of immature, non-functional blasts. This rapid accumulation physically crowds out normal production in the bone marrow, leading to failure.
Which manifests as anemia, neutropenia, and thrombocytopenia.
Correct. AML is more common in adults, while OWL is the most common childhood cancer, peaking between ages 1 and 5.
And chronic leukemias.
Chronic leukemias, CLL or CML, involve the accumulation of more mature, differentiated cells. These typically run a slower, more indolent course, although they can sometimes transform into more acute, aggressive forms.
Let's focus on the single greatest success story in targeted therapy. Chronic myeloid leukemia, CML. The diagnosis is synonymous with the Philadelphia chromosome. This is our rogue tyrosine kinase anchor.
CML is defined by a reciprocal translocation between chromosome 9 and chromosome 22, written as T922. This structural error fuses the BCR gene with the ABL gene, creating the notorious BCR-ABL fusion gene.
What does that fusion gene do?
It creates a protein with a single massive functional flaw. It possesses continuous, unregulated tyrosine kinase activity. It acts as a rogue tyrosine kinase, constantly sending grow and survive signals, driving relentless cellular proliferation.
And before the year 2000, CML was uniformly fatal within a few years.
It was. The management revolution hinges on the development of tyrosine kinase inhibitors, or TKIs, like imatinib.
They are the perfect molecular key for the perfect molecular lock.
They are. They specifically bind to the ATP binding site on the BCR-ABL enzyme, inhibiting its rogue activity. The results were unprecedented. CML patients taking TKIs now have life expectancies approaching that of the general population.
And you monitor them with highly sensitive PCR tests.
We monitor them using highly sensitive PCR tests for the BCR-ABL mRNA transcript, aiming for major molecular response, or MR3 to MR5, which really demonstrates the power of precise molecular warfare against cancer.
Shifting to solid tumors of the lymphatic system, we compare Hodgkin lymphoma, HL, and non-Hodgkin lymphoma, NHL.
HL is distinguished histologically by the presence of giant, multinucleated cells called Reed-Sternberg cells. HL is highly curable, often exceeding 90% cure rates in early stages.
And it's staged to the Ann Arbor system, treated with ABVD chemotherapy.
Often combined with radiotherapy, yes. NHL is a much more heterogeneous and complex group, often widely disseminated at presentation, frequently involving extranodal sites like the bone, GI tract, or skin.
The critical distinction in NHL is based on grade.
Right. High-grade NHL, like diffuse large B-cell lymphoma or DLBCL, is aggressive, rapidly fatal if untreated, but is highly sensitive to intensive chemotherapy, often leading to cure.
And the standard treatment for DLBCL.
The standard is the RCHOP regimen. The R stands for the monoclonal antibody rituximab, which targets the CD20 antigen expressed on B cells, showcasing another brilliant example of targeted antibody-based therapy combined with traditional chemotherapy.
Then you have the low-grade NHL like follicular lymphoma.
Follicular NHL is typically indolent. Patients can be asymptomatic for years, but it runs a remitting and relapsing course. Crucially, while it is highly treatable, conventional therapy typically does not cure it.
So you only treat when patients develop systemic symptoms.
Correct. Things like B symptoms, fever, night sweats, unexplained weight loss, or rapidly growing masses. Prognosis in NHL is often assessed using the International Prognostic Index, or IPI score.
Finally, we address the cancers arising from mature plasma cells, the paraproteinemias. The most common monoclonal finding is often benign.
That's monoclonal gammopathy of uncertain significance, or MGUS. It involves the presence of a monoclonal immunoglobulin, an M protein, in the blood, but the patient is asymptomatic, with no evidence of end organ damage.
And it's quite common.
It's very common, seen in 5% of people over 80. The risk of progression to malignancy is low, about 1% per year, so these patients are monitored actively, not treated.
When that clonal expansion becomes malignant and causes end organ damage, we diagnose multiple myeloma.
Myeloma is a plasma cell malignancy that fundamentally disrupts bone turnover. The malignant plasma cells release cytokines that potently stimulate osteoclasts, the cells that resorb bone,
which leads to the classic clinical features summarized by the acronym SUBA.
through calcium elevation, renal failure, anemia, and bone lesions, link lesions, bone pain, and pathological fractures.
Diagnosis requires evidence of the malignant plasma cells, the M protein, and that end organ damage.
And treatment has evolved rapidly. Fitter patients may undergo autologous hematopoietic stem cell transplantation, but newer agents like IMiDs, which are immunomodulatory drugs, and proteasome inhibitors like bortezomib have revolutionized the management, targeting different pathways crucial for plasma cell survival.
Now we transition to the high-stakes world of therapeutics, starting with transfusion medicine basics. Blood components are life-saving, but they demand absolute meticulousness.
The standard components available for transfusion are red cells, platelets, fresh frozen plasma, or FFP, which contains all coagulation factors, and cryoprecipitate, which is rich in factor VIII, VWF, and fibrinogen.
And every unit is rigorously screened.
Every unit for major transmissible infections, including HIV, HBV, HEV, HTLV, and syphilis.
But despite the incredibly low risk, for example, HIV-1 risk in the UK is about 1 in 25 million units, the risk is never zero, and transfusion carries the risk of transmitting emerging or unknown pathogens.
This is why the underlying principle is simple. Avoid non-essential transfusion. Transfusion is a therapeutic intervention, not a nutritional supplement. The historical concern over transmitting prions like VCJD via blood products underscores the need for restraint and strict indications.
The ultimate transfusion nightmare remains human error leading to a fatal ABO incompatibility.
This is a devastating acute event with a mortality risk up to 10%. It occurs because most recipients naturally possess circulating IgM antibodies against the ABO antigens they lack. For example, a type A person has anti-B IgM.
So if incompatible blood is given,
The recipient's IgM antibodies rapidly bind to the transfused red cells.
and IgM antibodies are potent activators of what system?
The complement system. Activation leads to rapid, widespread intravascular hemolysis, the catastrophic bursting of red cells within the circulation.
Which causes a massive inflammatory cascade.
The resulting release of inflammatory molecules and free hemoglobin causes acute symptoms like fever, pain, and shock, often progressing to DIC and severe acute renal failure.
The only prevention is strict adherence to administrative procedures, ensuring the patient's identity matches the blood pack label and the cross-match paperwork at the bedside.
Every single time.
Let's pivot to managing the coagulation system with anticoagulants.
Yeah.
We have 3 major drug classes. The oldest, warfarin, or the coumarins.
As we discussed, warfarin acts as a vitamin K recycling inhibitor, reducing the functional synthesis of factors 2, 7, 9X, and X. It remains essential knowledge because of its complexity. It has a very narrow therapeutic window.
Too little, and the patient clots. Too much, and they bleed catastrophically.
Especially intracranially.
Yeah.
And the monitoring requirement is non-negotiable.
Strict INR monitoring is mandatory.
It is, because warfarin's metabolism is highly variable, affected by genetic polymorphisms and vulnerable to countless drug and dietary interactions. The short half-life of factor 7 means the PT-INR is the first to change when warfarin is initiated.
Next, the heparins. Unfractionated, UFH, and low molecular weight, LMWH.
Both act by binding to the natural anticoagulant antithrombin, dramatically enhancing its ability to inhibit key activated factors, primarily factors S and thrombin.
LMWH is generally preferred now.
It is, due to its greater stability and predictable dose response, allowing for fixed-dose subcutaneous dosing without routine monitoring.
But UFH still has critical niches, especially in the ICU.
UFH is still preferred when rapid offset is required, like before urgent surgery, because its effects can be quickly and reliably reversed by protamine sulfate.
And we must detail the paradoxical complication of heparin use. Heparin-induced thrombocytopenia, or HIT.
HIT is rare but deadly. It's an acquired state caused by antibodies that form against a complex of heparin and platelet factor 4. Paradoxically, these antibodies activate the platelets, leading to massive systemic and devastating thrombosis, not bleeding.
How do we diagnose HIT clinically?
Diagnosis relies on the 4T scoring system, a clinical pretest probability tool that checks for thrombocytopenia, the timing of the drop, the presence of thrombosis, and no other cause.
And if you suspect it, you stop the heparin immediately.
Immediately, and you initiate alternative anticoagulants which do not cross-react.
Finally, the new kids on the block. The direct oral anticoagulants, the DOACs.
DOACs are revolutionary because they offer fixed dosing and generally require no routine monitoring, which simplifies outpatient management dramatically.
And they work by directly inhibiting key nodes.
Right. Rivaroxaban, apixaban, and edoxaban are direct factor JAK inhibitors, while dabigatran is a direct thrombin inhibitor.
Let's end this section by circling back to thrombophilia, the inherited and acquired clotting risks.
The most common inherited risk, especially in Northern Europeans, is factor V Leiden. This is a gain-of-function mutation that makes factor V resistant to inactivation by activated protein C, leading to prolonged activity and increased clot risk.
And the most important acquired cause of thrombosis.
Antiphospholipid syndrome, or APS. This is a highly prothrombotic condition defined by a combination of clinical events, thrombosis, or recurrent adverse pregnancy outcomes, and the persistent presence of specific antibodies.
The lupus anticoagulant, anticardiolipin,
and anti-beta 2 GP1. And persistence is key for diagnosis.
so you have to confirm it.
Absolutely. The positive antibody test must be confirmed on 2 separate occasions at least 12 weeks apart. This chronic acquired risk is critical to identify because APS-associated thrombosis requires long-term management, typically with warfarin, as DOACs have proven less effective in this specific population.
Okay, our final checkpoint. This one is to anchor the therapeutic principles we just reviewed.
Check-in question 3, therapeutics. Which specific class of oral anticoagulant requires strict INR monitoring because of its narrow therapeutic window and variable metabolism? And what essential vitamin does it inhibit the recycling of?
The answer is warfarin, and it inhibits the reductase enzyme responsible for recycling vitamin K. If you're able to recall both the drug and its mechanism, you've anchored the cornerstone of oral anticoagulation therapy.
You have.
This deep dive has spanned the entire field, from the bone marrow factory floor to the complexity of molecular genetics and modern pharmacotherapy. We've established several crucial memory anchors. We learned to use the MCV as the blueprint check to immediately classify anemia by defect. Is it a hemoglobinization problem, making it microcytic, or a DNA synthesis problem, making it macrocytic?
We saw the revolutionary power of molecular targeting with the Philadelphia chromosome, which provides the perfect target for TKIs and CML, transforming a fatal disease into a manageable one.
And we anchored the vital, life-saving necessity of safety in transfusion medicine, noting that strict adherence to identification and cross-matching protocols is the only defense against potentially fatal ABO incompatibility.
Absolutely.
It is clear that modern hematology operates on 2 dramatically different scales. On one hand, we are engaged in this highly specific, expensive, and successful molecular warfare against rogue genes in cancers like CML and DLBCL.
And on the other, we are still battling the brute force problem of deficiency. We covered that the single most common cause of anemia worldwide remains diet and blood loss-related iron deficiency, a problem of simple micronutrient access and sanitation.
This dual reality molecular marvels versus nutritional basics poses a profound question for us as future clinicians and for global healthcare systems.
That leads to our final provocative thought for you. Considering the amazing advancements we've detailed, from TKIs to CAR T-cell therapy for relapsed lymphomas, how much of modern hematology still relies on the fundamental global task of finding a lost micronutrient versus fighting a rogue gene? What ethical and economic dilemmas does this dual reality, the high cost of advanced molecular diagnostics versus the pervasive simplicity of global deficiency pose for resource allocation in clinical practice worldwide?
Something to reflect on as you continue your journey through medicine. Thank you for joining us for this deep dive into the foundations of hematology. We'll see you next time.